a few more people that are probably going to be coming in here shortly. And everybody online, you guys can still hear us there. Just a thumbs up, say hello, anything. There you go. Thanks, Stormy. Thumbs up. Nice work. Thanks, David. All right, before we get into today's case review, just thought I'd take an opportunity to discuss a little bit of a safety issue that we've identified thanks to Aaron. We have been doing some spot check audits of oxygen tank securement over the last month, even after I've kind of pumped out education, and we're still finding a little bit of some issues with that. So remember to secure all the tanks appropriately. And if you don't have the correct securements for the tanks, talk to the supervisor group and we'll get some stuff ordered through Chad. So what we want to do is want to make sure that we've got that top plate in place, right? So I should have the instructions for the top plate, should have those 2 nuts and bolts that correspond underneath. The strap securement, the issue that we've been finding with the strap securement is twofold. We've had a few of the straps that actually haven't been going through the back bracket. You can see that the yellow back bracket there. We found a strap the other day that was just literally around only the oxygen tank itself. It's not going to be holding anything in place. So make sure it's going through those back loops there that you can see the yellow part of the bracket. If you don't know how to use a ratchet strap, you can go and watch the video that I've attached to the PowerPoint that I send out to everybody. You know, the big thing with the ratchet strap is obviously just to make sure that it's tight and that it's secured so that the ratchet handle and the pawls are actually inside of those teeth. Otherwise, it could just easily unspool. The lashing straps are the biggest issue that we've been finding. The lashing strap has to go through the buckle and back around out the other way for the teeth to actually grab onto the strap itself. Otherwise, if you just pull it through the teeth in the same direction that the strap is traveling, it will not catch the teeth and it'll just simply be able to be pulled apart very easily. So it's not, you know, you can just pull it apart with one finger if you tried. So it's not something that is safe if you're just putting it through the way that is shown at the bottom there, okay? This is a nicety, but if you can, try to make sure that the pressure regulator or the gauge is facing out so that a spot check can easily be done every day. And lastly, this is the one that I found last week when I was just doing a quick inspection of things. Once you reload the oxygen tank back into the ambulance, make sure you put the bracket securement lock in the down position. If it's not in the down position, then the tank itself will be loose. And if we ever get into an accident or something like that, the bottle's going to go for a flight. Okay. They're big, giant, heavy bottles. If they're not secured correctly to the bracket, somebody could really get injured. So please do your due diligence, check your bottles regularly, and make sure that they're in place. If they're not done correctly, feed that back to us so that I can continue this education across, you know, more of our staff and maybe even go and do a little bit more hands-on training. I've done a little bit of hands-on training with people on this, and there's been a few people that just haven't known, which is fair enough. If you're never taught exactly how to do it, then it's difficult to know these things. All right, everybody see the PowerPoint online, sepsis PowerPoint? Nice. Okay, let's get into it. All right, so just a quick review of what sepsis is, right? We've got an infection in the body that leads to a release of lots of different chemicals into the bloodstream to fight the infection, and this triggers a systemic inflammatory response throughout the body. And this inflammatory response, including things like clots and the infection itself, can travel throughout the body and damage our major organs. And that can lead to some significant problems down the line, like multi-systems infections and damage inside of the body. So sepsis is a real killer of patients. The prevalence of sepsis in 2020, it affected around 750,000 patients in the US, and it was responsible for 20% of all in-hospital deaths. So that's a huge, huge number of people dying of sepsis every year. The mortality rate is really quite high, especially in our geriatric populations. And infection origins, the most common, right, are respiratory tract infections, urinary tract infections, abdominal, but there's also quite a few unknowns, right? Skin is another big one that we find quite often. So just to be a brief kind of review of our normal objectives for our patient, our case reviews here. We've got patient presentation. Morning. Morning. We've got the patient presentation we'll talk about. We'll review a little bit of pathophysiology, look at the interventions, treatment and transport decisions, and the protocols that are applicable to us, okay? So we're going to do, we're going to look at 3 different cases today. I've taken a little bit of feedback there, and people liked the fact that we went over 3 cases a little bit more rapidly instead of just 1 case, really diving super deep into it. So we're going to go through 3 cases today. Our first is a 59-year-old male. He's been unwell for 4 days. His initial impression was weakness and general malaise. And we gave him some fluids and treated it, and then transported the patient. So here's our dispatch information. We've got Mitch, and we've got Brandon on this job here. It's about 1 in the afternoon. We've got, let's see, dispatch and en route very quickly. Nice work there. And we're at the patient approximately 6 minutes later. We're at 300 Main Street, apartment 6 in Kimberly. I'm guessing that's a skilled facility. 300 Main Street in Kimberly. No, that's just a regular residence. Yeah. Okay. It's like an upstairs apartment. Okay. We've got a leave time of about half an hour later. So we've spent a little bit of time on scene, probably getting this patient from his residence into the ambulance, and we've transferred care shortly after. Actually, no, sorry. We're at the patient, then we're transporting in about 15 minutes, and then we're at Magic Valley, obviously, a little bit later because we're out there in Kimberly. So no major significant delays in timing for this patient. We've got, this looks like Medic 3 on this one. I can't see that we've got another unit responding with us, but. Right, so brief review of our sepsis protocol, right? We know that sepsis is a life-threatening condition, right? One of the things that we look for when we are assessing a query sepsis patient, right? It's very difficult to, guarantee that our patient has sepsis in the field, but what we can do is we can look at what's called the Q-SOFA score, all right? So if you think you have a patient that you're concerned about sepsis with, If you have a patient with a respiratory rate over 22, and this is for adults, systolic blood pressure less than 100, and they have an altered GCS, right? If they score more than 2 of these, their mortality rate is greater than 10%, right? So this is a pretty significant finding. If you find a patient that you think might have sepsis and has 1, 2, or all 3 of these findings, their mortality rate kind of escalates quite quickly when you find these things. Secondarily, if you have a little bit more information, potentially in the transfer realm, and you've got some blood results, a lactate is something that's really quite handy to have, and a lactate greater than 2. Is that for a VBG as well? Lactate greater than 2, it bumps up a little bit. It's like 2.5 for VBG, isn't it?
Pretty much like usually almost lactate samples are venous that we get. So I think venous is, so yeah, venous has to be like.
Yeah. So, I mean, even if it's a venous sample, lactate greater than 2 is still fairly indicative that you have a patient that is in shock, right? And they're not clearing the metabolic waste, okay? Some other things that we might be able to see, urine output is a really good indicator as well. I know I rode out with Kyle the other day on a job out in Buell, and we had a query kind of urinary tract infection patient that had very little urine output. That's kind of a really big red bell that's ringing for a query sepsis. Okay, so blood pressure obviously as well in the adult, less than 100, but we've got another range down there for a pediatric population as well to consider. Okay. Common signs and symptoms, right? This is talking about meningitis and sepsis, but specifically, what we're coming into seeing probably here in winter is a lot of these patients, right? We've got the classic vomiting, general malaise, including severe muscle pain, right? The blotchy, pale skin. If you've got patients with confusion and irritability, that's another really common sign, especially in our geriatric patients, where we're going to these nursing homes and the staff there is just saying to us, the patient's not acting like themselves, even though they might have dementia, where they might have cognitive decline. They're still more confused than usual, and they might be irritable. This is a really common sign for our elderly patients that they might have a systemic infection. So let's look at the relevant history for this case, right? They found the patient sitting upright on the couch, grunting. It's not a great presentation for a patient when they're grunting, not acknowledging EMS when they come into the room. We do have, looks like Rock Creek QRU is there. So that's great. We got some help. Patient has pale skin, and he's very slow to respond, right? It's a disheveled and confined apartment. So the patient's obviously not looking after himself very well, which is another kind of clear indication that this person might be at risk. We've got some medical history down here that leads us to believe that the patient's generally, not a great individual as far as his own health is concerned. AFib, COPD, right? Two really significant findings in a patient like this, okay? Especially at how old this patient was. This patient was only 59 years old, and we've got some significant comorbidities here for this patient, right? Doesn't look like we were able to get a med list. Obviously, the patient is a bit confused, and we'll see that later in the kind of review of what was wrong with this patient. Right, so our examination, even though the patient was a bit confused and not responding, I think they've dug a little bit deeper and found that the patient does actually respond and is alert and oriented. That's probably after quite a bit of stimulation and checking these issues. I'm not sure if Mitch or Brandon Don't have Mitch or Brandon here, and they're not online, so just got off yesterday, so. Morning.
Right. I heard you were talking about me squid to chicken.
Yep. I did say your name. In a good way. In a good way. So the patient has a patent airway. Lung sounds are clear. Cap refill is looking good for this patient as well. Okay, and we've given it a query sepsis as a working diagnosis, but also a green as far as category of acuity is concerned. So the patient's not looking too sick right now. Right, review of what we've done and how the patient's looking as far as vital signs are concerned. Right, so we've got the patient with oxygen requirements. We've got a patient who's quite tachycardic here as well, 130. Blood pressure is looking pretty good manually. The patient's been, like we talked about, feeling unwell with symptoms worsening today. And we've got an IV established. Patient was required to be extricated by a stair chair because he can't ambulate. It's too weak to ambulate, right? That's another kind of really clear indicator for us that we've got a sick patient here. They're not able to ambulate anymore. We can see that our next set of vital signs down here, our blood pressure has dropped really considerably. But as far as our Q-SOFA score is looking here, right, we've got those three really important categories that we're looking for. Only one category is getting ticked at the moment, right? We've only got a respiratory rate above 22. We've got a fairly normal blood pressure, and we've also got a patient who's oriented and alert. Okay, so they don't have an altered level of consciousness. So we only have 1 point on our Q-SOFA score so far. Can't see a temperature necessarily on this anywhere. I'm pretty sure they would have performed a temperature. In fact, I believe it might be on our next page here.
95.6.
95.6 axillary, right? Dude, do we regularly take axillary temperatures here?
Take whatever we get.
Yeah.
Yeah, I guess I would look at it, if you get an extra temperature that's a fever, like high, I would believe it.
Yeah. Yeah.
So it's like,
I think there's a broad range of normal when we're talking about axillary temperatures compared to an oral or a core temp, right? So, I mean, I think that the normal axillary temperature finding is anywhere from 95 to 98, right? So that's a pretty big range. And they're just not quite as accurate as an oral temp. Some patients obviously are not going to be really easily convinced of doing a good oral temperature. And obviously we're not taking core temps on anybody.
Especially when they're breathing 28 times a minute.
Yeah.
It'd be a little bit more difficult.
Yeah.
to get normal.
yeah, so I will say that if you can get a temp, like an oral temp and it's high, like any high temperature can be valuable. I would question that one because it's so low, although if you look at the SIRS criteria, which is kind of what we use a little more at the hospital, like temperature less than 36 Celsius is equal to a fever. Or so yeah, you could, assuming that was an accurate measurement, like,
yeah,
it's your second sign of sepsis. So yeah.
So, and that's a good kind of segue into talking about temperatures. So we don't always just have a fever in sepsis patients. Obviously, we have something referred to as cold sepsis, right? Where the patient is starting to decline to the point where their body is no longer really capable of mounting a response as far as a fever is concerned, right? So a fever is part of our immune response. We're really trying to bring our temperature up to the point where it's not so comfy anymore for those germs inside of our body, and they start to naturally die off. So if our patients are no longer mounting a fever response to a query infection, we need to be fairly concerned that, you know, they're not doing so well, right? That's the kind of the big takeaway here. Our blood pressure is still kind of going a bit lower, but we've got quite a bit of variance in our blood pressures here on the auto cuff, right? Again, that's kind of a normal finding, but I would be suspicious that we had two blood pressures that were trending down, and we still have a fairly sick patient in front of us, right? We've got a patient that is really breathing fast. We've got a patient who's got an oxygen requirement, and they're not satting at 100%. They're only satting at 97, 96%, right? Even on that higher flow of oxygen, they're at 6 liters. So we've got a fairly sick patient here still, with all things considered. Mitch has started some LR on these patients. LR is a great choice, and fluid is a really important part of helping these patients in the long term. So good job there, Mitch, getting some fluids in. We're certainly not at the point where we're considering, any type of vasopressor to keep our blood pressures up. Our blood pressures are still looking pretty good here, especially at the top. But as we can see, as we kind of come back down, again, we've got some significant hypotension. Now we are well below 100 systolic. Okay, so now we're ticking 2 boxes on that Q-SOFA score. And our patient's mortality, if we can remember our Q-SOFA score, we've got 2 now. So our patient's mortality is looking somewhere around 2 to 3%, right? And you could maybe even argue that this patient, earlier in the case, not responding so normally, very delayed response. You could argue that that might be a third point there. Okay, he's kind of right on the edge. So we still have a fairly sick patient here. Right, so let's look at the rest of our clinical practice guideline, and we've got oxygenation, right? Aggressive oxygenation. They did a great job there. They obtained a temperature, okay? Blood glucose. Let's see, did we have a blood glucose included in here? Didn't necessarily see one.
Could have been gotten by the fire department and documented on page 7.
Right, so blood glucose, another kind of important factor when we consider looking at these patients, right? Because if we have a patient that has a high or low blood sugar, it's also an indication that we might have something significant going on. So obtaining a blood glucose level on these patients is something that's really important. If you have signs of shock or hypoperfusion and a lactate of greater than 4, obviously we're going to be getting a lactate in our interfacility patients. Yep.
I was just gonna add something that's interesting. So, lactate is kind of a big marker for sepsis, there is some decent studies that showed you can actually use end-tidal CO2 to kind of figure out a lactate. So it seems like you're familiar with that.
Yeah.
So basically, if you're end-tidal CO2, so, if you have a little bit of metabolic acidosis, you have sepsis, you're going to be a little more tachypnic. And so if you see like an end-tidal CO2 less than 25 in a patient, it has a high, at least a reasonable correlation to a lactate greater than 4. So there are some places that will do point of care lactates. It's just kind of an expensive test. And, if we can kind of reasonably, pre-hospital assume that the lactate is high, we can kind of get there with what we have without adding extra things. So I just thought that's an interesting point.
Yeah. I think as well, there is a really good argument here to do end-tidal CO2 monitoring. We've got a patient with a history of COPD. We've got a query sepsis patient, and we know that a significant amount of our patients that have sepsis, the origin of that sepsis is coming from their lungs, right? And so if we have a patient, history of COPD, history of query, some issue going on there in the lungs potentially. If we put this person on an end-tidal CO2 monitor as well, and we start looking at capnography, we can probably glean a little bit more information off of what the waveform is doing as well, right? Mitch did a good job here. He listened to lung sounds and the lungs were clear. But I think very rarely are we listening to lungs in all fields from the rear of the patient, right? And getting really good lung sound assessments. The vast majority of us are probably just doing it from the top end and then maybe going mid-axillary occasionally as well. But if we're not actually listening to every lobe of both lungs, it's going to be difficult for us to highlight somebody who might have a bit of something hanging around in one of the bases down there. So end-tidal CO2 would be a great way to help differentiate what's going on with this patient specifically. And as Dr. Bird has said, the higher your end-tidal CO2, the more kind of indication you have that the patient is acidotic, right? And their pH might be trending towards a lower number.
It's actually lower. It's low because they're too counting.
Oh, yeah.
Opposite way. Yeah. But still good.
So if they have a low CO2, they're breathing really fast, they're getting rid of a lot of that CO2, right? I've seen patients who are breathing really fast and still have a high CO2, but in this case, probably with clear lungs, you're probably right. Your patient's probably going to have a lower end-tidal CO2 than what you would normally kind of see. Right, if our patient fails fluids, right, and I don't think we had this patient long enough for him to kind of have failed fluid administration, but if we're failing fluids, our drug of choice here is norepi, right? A norepi infusion is really our first line to try to get some peripheral vasoconstriction going and help that perfusion of our major organs, brain, lungs, kidneys, all those other major organs that we have in our body. Epi is another consideration that you could certainly use, but as you can see, a lot of these patients' heart rates are really quite high. And if we're going for an epi infusion, that could have some consequences that we're not hoping for, right? But it is a good consideration if you've got a patient who's decompensating and or maybe their heart rate isn't that high because they're on a litany of different blockers to keep their heart rate low. So you've got a few choices there. It does say consider vasopressin. I don't think we're doing any vasopressin drips
We don't
in
have
our facility.
Yeah, well, we used to have it because it was part of ACLS, and that's just a discussion that's an ongoing thing. Because it actually is a better second line vasopressor in sepsis. It's the last one you take off, but it just, can we have every single thing in the back of the truck all the time? That's what we're trying to discuss. But anyway, it's on we're looking into that, but yeah.
Yeah.
So,
Okay. Yeah. Thank you. Thanks. Right. If we, skip forward there a little bit. If we have a patient, especially a pediatric patient, right, who is still fluid refractory and vasopressor dependent, we can consider adrenal insufficiency. Adrenal insufficiency is quite common in septic patients. The adrenal gland is affected significantly in sepsis patients, and many of these patients will not be able to produce enough of their own cortisol to be able to keep their blood pressures up. And so one of the things that we consider there is, for us, we've got some corticosteroids, right? Now, this is medical control consideration, and really we're only going to be considering this in the interfacility environment, right? But if you get to a really sick sepsis patient, ask about their adrenal sufficiency, right? See if it's been checked, especially at the crit care level. We've got some of our flight staff here. When you're taking these patients, ask about that consideration and see if it has been considered. Okay.
And I think it's kind of changed, over the years where if you're on more than like 2 vasopressors, the person's like having refractory shock. They are starting to do the stress dose steroids now, and we don't care so much about the cortisol level anymore because it's a clinical picture, you know. The real test is if you have an abnormal cortisol, it depends on the time of the day. Then they're like, oh, do a cosentropin stimulation test. It's like you don't have time for any of that. If a person's in refractory shock, more than 2 pressors, it's like going to steroids. But so yeah, I think it would be a good chance to advocate for your patient to ask for, you know, the hydrocortisone. Since we don't have that, that's kind of the optimal corticosteroid. So anyway, it's an interesting discussion, but it is something that is becoming more, people are more comfortable with dosing that in severe sepsis now. So.
Yep.
Yeah.
So patient follow-up for this patient. The patient had a query pneumonia that he was probably recovering from on chest x-ray. They didn't think that it was significant enough to have contributed to his presentation as sick as he was. So he was not actively treated for the pneumonia because he was either recovering from it on his own or it didn't pose as big of an issue as, you know, what the future considerations for his care were. But what they did find was that this patient did have adrenal insufficiency, and it was likely caused by the prescription of multiple serotonergic drugs, okay, and that was suppressing his adrenal gland and subsequent cortisol production. This can kind of mimic. Somebody's calling somebody. Yes. But let me see. Okay, she muted herself. Okay, cool. So adrenal insufficiency, like we talked about, can happen in sepsis patients. So, you know, kind of the working diagnosis for this patient was his adrenal insufficiency was likely caused by the multiple medications that he was taking, but could have also been influenced by having a significant infection in his chest as well. And when I looked through this patient's history, he did have quite a litany of previous chest infections on his record. So ex-smoker, still occasionally partaking in tobacco per his record, and so he had some significant issues going on there. And they sent him home a few days later. Responded well to a bit of medication. Right, so sepsis and pneumonia, we talked about it briefly, but pneumonia is really a massive cause of sepsis, right? So this study here looked at, you know, around 1,300 subjects, right? We had 4 to 5% patients had acquired community acquired pneumonia and developed septic shock. And patients with community acquired pneumonia developed severe sepsis in 48% of the cases, right? So when we talk about sepsis, there's 3 common categories of sepsis. There's kind of the initial phases, there's severe sepsis, and then there's septic shock, okay? And we'll talk a little bit more about that in our next case here. Right, did we have, no, Brandon, no, Mitch online either, so we don't have any crew insights to this one. So we'll skip over that, but did anybody see anything on that case that they wanted to discuss a little bit more? No? Cool. Right on to case number 2. 67-year-old female patient, altered level of consciousness, initial impression, COPD/sepsis, right? We treated and transported the patient. Got Andrew on this case over here, and we've got Garrett Dusnip. I don't think we have Garrett online, not in today. We've got a patient again out in Kimberly. Came in quite early in the morning, about 9 a.m. They were at the patient very quickly after being dispatched, and they left about 15 minutes later. And we know the normal transport times from Kimberly, so we didn't have a massive delay, about half an hour to 45 minutes with this patient. Right, our relevant history. We've got a patient here who is lying prone in her room with fire department staff attending. She's noted to be not alert, but has her eyes open. Care staff is waiting at the door with paperwork, I'm guessing. Right? History of shortness of breath. The patient's been having trouble breathing all morning, and then when they went to check on her, she was not responding, and she had very loud, coarse breathing. And they noted that she'd not been feeling well for the past day. She's got some significant respiratory pathology there as well. She's got COPD. She's got a history of respiratory failure and emphysema, right? So not a very well lady. I'm guessing we probably had medications, but we just didn't get those listed if the staff had paperwork. Okay, so we've got a patient with a GCS of 6, not looking too great, okay? Alert, but not responding to stimuli, okay? I'm not sure about that finding personally myself, but if I don't have a patient that is responding to verbal stimuli, I'm not sure how they could possibly be alert. Andrew, you want to just chime in on this one? Do you remember it at all?
Trying to remember it. I think it was the older lady. From what I remember, she had like audible expiratory wheezes. Definitely wasn't alert. Pretty rotunded.
Yeah.
Would kind of withdraw from like a sternal rub, but not like a whole lot. She had sounds like she'd been sick for a couple weeks. And they went and checked on her and they're like, well, she's starting to get worse. And then we went and checked on her and like, she's definitely worse, but she was pretty out of it.
Yeah. So we want to, I think, and I'm not trying to pick on Garrett here. I think the thing that we want to try to do in our documentation is make sure that it is fairly consistent, right? So we've got a patient who's by all kind of accounts unresponsive, really. And so if we're documenting that there's a level of consciousness that's alert, but at the same time, a mental presentation of unresponsiveness, those two things just don't really match up from a documentation perspective, right? But we're going to go with the GCS of 6 being not alert.
I do notice this a lot with the pre-hospital report, because I think we get into like our lane, or, you know, you get in your speech where you say, we have a 40-year-old patient awake and alert, comatose, you know, I don't know. It's one of those things where actually, I think we all know what is going on with the patient. I think it's just being more precise with our language and documentation. It's something that I have those kind of mistakes in my charting as well, but yeah, just something to keep an eye on, I guess.
Yep. So yeah, and like I said, I'm not trying to pick on him at all here. I think this is a really common thing when I read charts. I find just these small little things here. I think there's enough consistency in this chart that we can take away that the patient is very sick and has an altered level of consciousness, right? Respiratory wise, the patient's airway is open. They've got crackles on both left and right, very coarse crackles, but no obvious fluid in the patient's mouth. All right, so it doesn't look like she's potentially aspirating currently. Shallow breathing with an increased rate and probably a significant work increase as well. So let's look at a little bit more of our documentation here. So initial SpO2 from Kimberly Curie was 73 prior to oxygen, right? So we've got a really quite decompensated patient as far as that is concerned. And the first rate that we get here is about 45, right? So we're ticking 1 point for our respiratory rate already. We're ticking 1 point for altered level of consciousness that we could see as well on our Q-SOFA score. And additionally, we're another point for systolic blood pressure less than 100, right? So we have all 3 points on our Q-SOFA score, greater than 10% mortality for this patient, right? Andrew's come in and slotted an IV for this patient. Nice work. Single attempt. Does also note up here that the patient is not for intubation and not for CPR. Okay, so we've got a patient who's well-known. She's in a care facility. She's got some significant comorbidities and she has a DNR in place, right? That certainly helps us to make some good decisions for this patient, because I would kind of look at this patient and say they are peri-arrest, okay? They're not really doing very well, okay? Looking at the trend as well, we can see that the patient's quite shocked and remains quite shocked, which is not surprising given that they were found prone, probably with a significant airway constriction and low SATs. We've corrected those things and we've put the patient on some oxygen, and we're seeing some significant improvements, right? We're seeing our oxygen saturations come up quite nicely. We're seeing our heart rates come down a little bit from the initial kind of assessment. And we've got a little bit of a rebound in blood pressure there as well, which is nice. But she still is definitely teetering on the edge here, all right? I'm looking for a temp, but I don't see one. We do have as well some CPAP initiated, which I think is a really good call for this patient, right? We've got a patient who's got some significant respiratory findings. She had coarse crackles in both lungs. I think CPAP could potentially help this patient, but we do need to consider that her blood pressure is quite low, right? So we're going to want to be chasing that with some fluid, which is what we do. We chased the blood pressure with a bit of fluid here. So Garrett's done a good job getting some fluid into the patient. We've got some oxygenation and CPAP initiated to help the respiratory dynamic. So things are looking pretty good. I think we're on our way to some really high quality care here.
Was that CPAP with the old CPAP stuff, or was that with the
vent.
ventilators?
Yeah, the vent.
With the bed.
Yeah,
With the ventilator?
with ventilator, yeah. Documented.
It's just the documentation change that we need to look at.
Yep. So this one, I'll get with Garrett because obviously he's not here. And I don't want to pick on him while he's not here, especially. So I'll talk to Garrett a little bit about, the documentation. Garrett's a great medic. I think he's doing a really nice job here. There's just a few things that we can polish up documentation wise. Do you have something to say?
Well, I just was interested, so we said the sugar was missing also in this.
I don't see a sugar documented. I'm imagining you guys got a sugar.
In this case too,
I don't remember one. I can't remember fire going.
I'm not super worried about it. I just was gonna mention that, but then, did you guys have like a rhythm, interpretation at any point of the heart?
It says sinus tag.
Sinus tag.
Okay, I mean, and was that based off of like the, 2 lead, or what was that? Because, I'm just interested in it goes up to 164, to make sure that was actually accurate, like maybe actually get a, just because it's the heart rate's going up, you're kind of, is this person in fib or flutter? Although conceivably it could be sinus, I guess I just wanted to, maybe there's a rhythm strip at the end of the chart, but that's what interests me also. It could be sinus.
The other thing too is like oftentimes once you start driving, lots of the artifact will go into the actual number and people don't often change that. So that could be misleading too, to the actual rate.
Yeah, absolutely. Yeah, no, that happens all the time in the ER where you want to put the vital signs through onto the chart formally, like make sure we're paying attention to that. But that happens a lot in the ER too. So.
Yeah.
Their blood pressure there at 918 obviously wasn't 127.
But
Yeah, 127 over 95 is probably not consistent with the
80s.
with the 80s that we were having, and also the lower, diastolic pressure that we were having as well. Cameron, I think you might have.
Nothing, I didn't say anything.
I think you might have put us in your pocket, Cameron. Somebody want to send Cameron a text message?
Well, this guy wrestling, so we don't want to say that.
Morning, guys. Right, so, I mean, when we look at this treatment for this patient, I think we have to remember two things, right? We've got a patient that is a do not resuscitate, a DNR patient. And we've got somebody who's peri-arrest. And we're doing some pretty good stuff here. We've got high flow oxygen, we've got IVs initiated, we've got fluid going in, we've got good airway management, and we're also helping the oxygenation significantly with a bit of positive end expiratory pressure. All of these things are really good for this patient. Okay, and we can see that if we consider the patient's trend from when we arrived to when we arrived at ED, we've got a significantly better patient, okay? We've normalized the patient's blood pressure above 100. Whether or not our ECG is actually correct there for our heart rate, it's probably not. We've normalized blood pressure. We've gotten SATs up to 94. The patient's still breathing really fast, and we haven't changed the GCS, but we've made some significant strides for this patient. And I think we've recognized the severity, and we haven't really dilly-dallied too long on scene doing things that might make the patient considerably worse. The other thing that we have to remember here is Garrett was kind of constrained a little bit with this no intubation, no CPR, right? So traditionally, I would think that many of us would look at this patient as needing an advanced airway, right? They have a low GCS. They've got a significantly high respiratory rate, and they're very shocked, right? This patient is at real risk of going into cardiac arrest, and without an airway in place, it's going to be very, very difficult to manage the patient, let alone do anything once they get to that kind of, borderline PEA style arrest, right? Our hands are really going to be tied here, and we're just going to have to watch the patient kind of pass away. So these are really difficult cases, and I think Garrett's done a really nice job here. The question is, should we have probably done maybe a bit more fluid for this patient? I would say, I think I'd probably have put up a pressure bag and probably tried to get a bit more fluid into the patient. I don't know, Andrew, whether or not the patient would have had good veins for multiple IV sites.
Not really, she was pretty frail.
Yeah. So
You do got the IV in the hand, you could put some fluid in with a restrictor above and see if you can get something bigger and higher. It's a possibility, but you never know.
Yep. Obviously we also have IOs that we can fall back on as well for a secondary placement. I would think that this patient with a GCS of 6, if you're having any difficulty getting another IV established, that we would fall to an IO, right? I put IOs in plenty of patients like this with lower GCSs, and they work quite well. So I think good job overall. There's a few polishing points for documentation for Garrett here. Any other pointers that anybody wants to talk about with this case specifically? Lindsay? No? Storm?
Andrew, how do you feel like this call went for you?
It's okay.
You were there.
It's hard because she has a DNR, DNI. With my limited knowledge, I definitely would have considered probably RSIing this patient had she not had that in place, but obviously that's a factor. She didn't initially tolerate the CPAP at 10, so we adjusted it a little bit. I think it was like 7.5 or 5. And she seemed to do a lot better on that. I don't know, like, given the situation, I think it went as well as it could have. It's just, it was a tough situation, like the care staff was pretty poor historians from what I remember.
Yeah.
So we didn't have a whole lot of like what to go on, and they're kind of like, well, we're new to this, our patient, we don't know, kind of thing.
Yeah. The classic care home patient, right? So I just try to bring the QSOFA score back because that's one of the tools that I'm really trying to highlight today. Obviously, this patient had all three factors into play here. They had a lower GCS, they had a systolic blood pressure less than 100, and they had a respiratory rate above 22. Patient follow-up for this one, okay? I think we all could have guessed that it was probably pneumonia from the presentation. So this patient compared to our last patient, there is an obvious difference here, right? We've got a patient who has what's classified as severe sepsis, right? So we're not in the beginning phases of query sepsis anymore. We're into severe sepsis, right? We've got multifocal pneumonia, right? And what that's telling us is that she has an infection in multiple places, usually either in multiple lobes or in both lungs. We've got a patient who's hypernatremic, okay, which essentially means that the person usually is very fluid depleted. Okay, when you've got a hypernatremic patient, and Dr. Burtis probably expand on this for us a little bit, but also hypernatremia is a common finding in our sepsis patients because they've lost a lot of fluid, right? They're not, and one of the reasons why we give patients so much fluid in the first place is to help combat things like this, okay? So hypernatremia is a common finding in our sepsis patients. Well, maybe not common, but it's something that you do see. The patient has acute chronic respiratory failure with hypoxia and hypercapnia. One of the things that I would have liked to have seen on the documentation here is a end-tidal CO2. I don't see an end-tidal CO2 anywhere on here that I can see.
I don't think they would have been able to get that under the
CPAP.
current CPAP that they're using with the ventilator.
You can put it in line.
So you can put it in line. It's not going to be wholly accurate, but especially in the decision leading up to CPAP, you could certainly put our end-tidal CO2 monitoring on underneath the mask. We had a requirement where I used to work that we used nasal prong CO2 detectors underneath our CPAP masks.
For years, it was drilled into us that they were expensive and we were not to touch them except for on that like very rare case. And now Dennis is gone.
And if that's the case, if that's what people are afraid of using our end-tidal CO2 samplers for, throw that out.
Yeah.
Throw that thought out.
Yeah, because that was, I think that was the Denny thing.
If you have,
But it was very much like, those are $6 more than a nasal cannula, so.
doesn't matter. If you have a need for that information, we need to get that information.
Yeah,
Yeah.
so I think that's just habit. It's,
I think it'd be really cool, Eric, to have a really good education on end-tidal and all of the different things that it can do and show you, waveform numbers, how it all correlates. I think it'd be really cool education.
Yeah. There's definitely pros to trying to monitor somebody's end-tidal CO2 here. There's some difficulty in it as well. So I'm not harping on anybody that doesn't have the nasal prong CO2, try to get one underneath a mask. It's a whole nother layer of complexity.
What's the reasoning behind going with the nasal cannula versus just throwing one in line? Because I've been putting them in line and they seem like I'm getting good readings from it.
If you can with the CPAP mask.
So you just put it
do it.
towards the ventilator side and it works. Yeah,
If you can, then do it. Yeah.
I
Personally, I don't have enough experience with our Zoll ventilators and the tubing to understand that myself.
Yeah, we just had one the other day and he was like quite hot, right? Breathing lots of wetness. And so we put a HEPA filter to the patient, end tidal right after that. And he didn't tolerate it in the end, but we were getting really good accurate readings and you could, get a good idea of his like respiratory status with it.
My biggest concern about this patient is that patient level of consciousness high enough to manage that CPAP pressures.
Yeah, right. And what we would probably want to do differently is BiPAP instead of CPAP,
Yeah.
right?
Oh, yeah.
Because this person, if she's hypercapnic failure and she's obtunded from that, yeah, you need some
Pressure
increase in
added to that.
ventilation rate. Yeah.
Yeah.
The ventilation volume. So, yeah, so anyway, it's just a thought, but we don't have all the time in the world. We have not a.
Well, the other thing too, is it wasn't documented under the ventilator. So, when you do CPAP,
Right.
there's only a box for the PEEP. There's not for, so it could have been, that they
Right,
put
yeah,
that in.
and
there,
anytime
but
we use
it's not
the Zoll-
documented.
That would be nice.
Anytime we use the Zoll
Yeah.
ventilator, it should be documented under ventilator setting, not under airway.
So I think a lot of this for Garrett is obviously he's not full-time with us. He's working at another service full-time and he's coming in and helping us staff ambulances, which is great. So I commend him for that. I think depending on your level of experience with our ventilator, it's going to be difficult to utilize. And so, we've got some training coming up on December 5th, and I specifically go over a lot of these things in the training, and I'll be doing more ventilator training moving forward. So I'll put those days out here shortly, but, for us here, one of the things that end-tidal CO2 monitoring can help you with on a patient like this is you can look and see how often the patient is breathing. And it's pretty accurate, right? It's also a good indicator on whether or not the patient is maintaining their own airway, right? Because if the waveform is not of normal kind of shape and size, we can ascertain that there's some constriction going on somewhere with our capnography, all right? And then as well, capnometry is also going to lead us down the road of whether or not our patient's probably really shocked and not perfusing, or if they're perfusing well enough and we're getting normal numbers. Okay, those are good indications on whether or not we're increasing the perfusion of our patient a little bit, okay? So we should see increasing end-tidal CO2 numbers with better perfusion, kind of profiles as we resuscitate our patients, okay? So we'll go back to the diagnosis here. We can see that initially, once we got our patient to the hospital, we were pretty sick. Okay, we had a pH of 7.3. Okay, we had a PCO2 of 51. And in our shocked patients, the correlation between end-tidal CO2 and actually a blood gas, CO2, it gets more deranged as your patients get sicker, right? So I wouldn't expect to see an end-tidal CO2 of 50 for this patient with a low blood pressure like that. It's probably going to be low, like what Dr. Burrs was talking about here, where if I've got a patient who's breathing really rapidly but not perfusing, they're going to be blowing off the CO2 in their lungs, but they're not going to be actually getting rid of it from their bloodstream into their lungs. That's right. Right? That is. Yeah. So also our PO2 is quite low, right? So we've got a patient who's not getting oxygen in. And again, that's a very clear sign that we've got a ventilation perfusion mismatch going on here because of the shock, right? Our bicarb's pretty normal. Not too terribly wonky, which is good. But we can see there that obviously the patient is not doing well. They've got acute renal insufficiency as well, obvious respiratory acidosis. Okay, and they've got a positive finding there for streptococcus. Okay, so once we start talking about what causes our pneumonias, right? I've kind of highlighted there the streptococcus strain of bacteria, very common cause of pneumonia. And I kind of wanted to bring this slide up a little bit because I think a lot of times when we go and we see these patients, we put ourselves at risk because we're not putting PPE on, Okay. Kyle brought up a good point where you not only want to protect your patient from the ventilator, okay, with a HEPA filter, you want to protect yourself from the patient with a HEPA filter, right? And one of the ways that you can do that is put a HEPA filter on the end of your expiratory circuit on your ventilator tubing, okay? The gas that's coming out of the patient now is going to be filtered so that you're not breathing in all of these nasties, right? I've seen quite a few of my colleagues get hit pretty hard with stuff like this from very sick patients. So don't get lulled into a sense of security just because you've got a mask on somebody or because they're not actively coughing at you. If you think that they've got a significant pathogen that is causing them to be really, really sick, it can transfer over to you, right? And it can also transfer over to your next patient. So please clean your equipment responsibly from patient to patient. Healthcare acquired infections like this one. This is almost certainly a healthcare acquired infection because this lady is in a care facility, right? It's a really, really big problem. So we want to make sure that, we're doing our best to keep our patients healthy. Okay. Right, on to case number 3. We've got a 54-year-old male, initial impression, blood in a colostomy bag and query sepsis. We've got Dan and Josh over there, and we've also got Chris DeVos in on this case. It's about 4 PM. Our in route and at patient times are pretty good. We're out there in Buell and we're coming from Medic 5, so that's normal response time there. And we're with the patient, about 13 minutes or so. It's a pretty good turnaround time. And then we've got the normal transfer time out there from Buell. Were you on this one as well, Noah?
I think so.
All right. We've got a round robin then. Okay, so patient's laying on his right side on a hospital bed in his home living room, right? So we know we've got a sick patient pretty much straight away because we've got a patient in a hospital bed in their own home, right? We also knew that the patient had a colostomy bag, so we know that something significant is going on there. And as we can kind of see a little bit farther down, we've got a patient with paraplegia. So we've got a patient with autonomic nervous system disorder, colostomy bag, hypertension, paraplegia, seizures, UTI, a lot of different things going on here. The patient colostomy bag was noted to have blood clots in it. And he also had a wound vac over a sore on his back. He had also previously been treated for a UTI recently. So we've got 3 real potentials for a serious infection here. We've got colostomy, we've got a wound, an open wound on the back, and we've got recent treatment of UTI, right? And still currently on oral antibiotics, okay? Great documentation here. All right, so our examination of the patient, we got a GCS 15 patient, right? So that's great. We don't have any altered level of consciousness. So we know we can take one of those points or keep one of those points on our QSOFA score pretty much straight away. The patient's alert, oriented. They've got normal pulses present. And I'm guessing their skin signs are looking pretty normal as well, warm, dry. So we talked briefly about the stages of sepsis, right? And this is kind of a very common kind of question that I've been asked in the past. What is sepsis? How do you categorize it? And this is a really easy way to start to categorize it. So you've got stage 1, really, which is that infection and inflammatory response. And many patients will be able to cure themselves in this stage, right? If you're young and fit and healthy, we've all been sick before. We've all had significant infections, and our body's been able to fight it off, right? Once we start to get towards our organ impairment, we're moving more towards severe sepsis, right? We've got low blood pressure, we've got oxygen issues, we've got retention of acid, especially that lactic acid, which is leading us to severely reduced blood flow and eventually shock, right? And the shock is going to dilate our blood vessels. It's going to make them really leaky. That pathogen and all of its, causations for acidosis and deprivation of oxygen is going to compromise our cardiac output eventually. And then we're going to lead to, system-wide failure, right? As soon as our heart is not able to perfuse the rest of our organs, we're on our quick way to death, okay? So those are the three classic phases. So looking a little bit more at this patient, right? We have, going back to our Q-SOFA score, we've got a patient who initially is looking quite good, right? We've got a normal blood pressure. We're quite tachycardic, but the blood pressure is looking good, right? Our respiratory rate is falling below the 22 breaths per minute. So we're not ticking any boxes there. And it's not until about 20 minutes into our care that we start to develop a little bit of hypotension, right? We've got some IVs initiated. Great job. I don't see, again, a temperature. Do you guys remember doing a temperature on this patient? No. Okay. Blood sugar? PCS is 15. But the reason I wanted to highlight those two things is because I think a lot of times we look at a patient, GCS 15, otherwise doing quite well, and we go, there's no need for a blood sugar, right? Patient didn't have a history of diabetes either, right? So it's important for our sepsis patients to have that BSL, not only just because it's in the protocol, but it's a clear indicator for us in many cases whether our patient is developing sepsis. High blood sugars are a really common finding in a sepsis patient. So if you have an abnormally high blood sugar, it would lean you again towards being suspicious of sepsis. Okay. It's also part of a good resuscitation profile for somebody whose blood sugar might be a bit low there as well, right? Maybe they're bordering on being low, and we want to think about a nice balanced fluid administration for these individuals. We might consider T5. Yeah, we might consider a bit of sugar for these patients, okay? That's good history taking, and it's good patient care, right? What we do have here is really great documentation and really great reassessment of our patient. You guys noted hypotension, and you went, let's double check that, right? And pretty much straight away, we're back into checking and confirming that the patient actually is hypotensive, right? So I think that's a really important finding for us. We want to make sure that if we've got a patient on our first set of bottles there, 1625, looking quite good, right? And now all of a sudden we've got this really rapid drop in blood pressure. My first instinct would be to say, I'm not sure if I trust that, right?
Was there another blood pressure attempt in the middle of that?
I think it was, took so long because it was hard getting out of the house. It was a really tight house.
Probably
So,
part of the reason.
so I think that was the reason that there
There's
was.
typically, what's it run automatically every 10 minutes?
Yeah, we took it off over, but
You have it set at 5 minutes. Most people change it to 10.
Yep. And this happens all the time, and there's not much that we can do about it, right? Especially if you've probably gotten there, Noah's done an assessment on the patient. He's looking at the patient going, patient's alert, oriented, perfusing well, right? You guys have confirmed that and gone, okay, we've got some time to move the patient out, right? Yes, they're a bit tachycardic. Yes, they're probably a bit sick, but they're holding on for now. We can move this patient out, okay? This is totally normal. But what I really liked was that you chased that blood pressure straight away and went, let me just double check this. Let's just really make sure of what we're doing here, because we can be tricked in a lot of these patients sometimes with auto cuffs. And I know, Josh, you've talked about this on repeat, which is great. We want to confirm our blood pressures manually if we think that there is something that is amiss, right?
All states that our first blood pressure was manual anyways.
Yep. And I imagine, Noah, if you were there, you would have got a manual pressure on the patient, right? And it probably would have married up initially with what you found on your auto cuff. And so there's probably really good assessment of the patient initially. And when there was a significant change, we have backed that up with good reassessment again, right, in very short order. And obviously, we've got a hypotensive patient now, right? And so they're going to need some fluid. So job well done there, getting some fluid into our patient. Only 1 point on the QSOFA score though so far. We've got a blood pressure that's rebounded quite nicely after a fluid bolus, right? So things are looking quite good there. And we've transported the patient without any other significance. So I'm putting down here at the bottom, query urosepsis, right? But we had multiple other sites of potential infection. Anybody want to take a stab at what they think was the cause of this patient's sepsis? Do we think urosepsis? We thinking that it's from a skin-borne pathogen on the open sore on the back? Do we think it's from maybe the colostomy bag? What do we think might be going on with this patient?
I think it's a GI.
Going GI? What did you guys think?
Urosepsis would be my guess.
Urosepsis was your guess? Yeah. Anybody else want to weigh in?
Stage 4.
Right. So we had urosepsis. Okay, so we had a patient, urine culture was taken. This patient had an indwelling catheter. Okay. When we start to see patients with indwelling catheters, have a very high suspicion if you're thinking the patient is sick and potentially trending towards being septic, that the cause of that sepsis could be urosepsis if they have an indwelling catheter, right? Remember, this patient was a paraplegic, right? And so they've got a indwelling catheter to help because they're not able to functionally use that part of their body anymore. So you can see on the urine assessment here, we're flagging red for pretty much every finding that we can get, okay? And what they've done is they've cultured it and found Morganella. So anybody that's been in healthcare long enough has probably heard the term Morganella before, right? Morganella is a common finding in our GI tract, okay? And many times if you have patients, this is a very common finding for female UTIs in the nursing home because we have the wiping from back to front going on sometimes, right? So it's not quite as common in men, but if you have an indwelling catheter, it does become very common, right? Looking at the chemistry profile over here at the very top for inflammatory markers, that lactic acid, 3.9, okay? So remember we had that number, I think, on our protocol. So we had a lactate greater than 2, okay? And then we also had a little bit farther back in the other protocol, okay, here. A lactate greater than 4, right? So we are really right on that lactate of 4. And in fact, I didn't add it into this, but his subsequent lactate about 2 hours later was 4.6. Right? So this would be classified as severe sepsis. Okay? So he was maintaining quite well, even in severe sepsis, wasn't he? But what we found was that he probably decompensated a little bit after we moved him around and kind of, stirred him up a little bit. If we look at our UTIs, this is kind of the normal progression of UTI. And obviously we've got a bit of a male anatomy over here because we were dealing with a male. Okay. This gentleman's follow-up was he had Morganella caused cystitis. Okay, so he had a significant bladder infection. So was his indwelling catheter, was it through the skin or was it through the urethra? Do you guys remember that one?
We didn't let.
Yeah. That's okay. That's fair enough. That's fair enough.
We got big as the nurses.
Yeah. So if you're investigating these things, okay, it's good due diligence from, right? And I totally get where you're coming from, right? I don't need to expose and examine every last bit of the human body in many cases. But if you've got a specific finding that you're thinking about in your secondary assessment, it might be worthwhile investigating, right? Because if you've got blood in a indwelling catheter tube, right, or in the bag, or something like that, that would lead you to be very suspicious that there was a finding there. And we don't know, maybe when this gentleman gets to the hospital, they just drain his bag and nobody even has a check of it straight away, okay? And it might go unseen for a little bit of time, right? So we want to have eyes on these things, especially if we're thinking that that could be a significant cause of the patient's presentation. When we look at urinary tract infections or urosepsis in this case, okay, we've got a lot of different types of causes here, but gram-negative bacteria is the most common cause, and that's Morganella. Morganella is a gram-negative bacteria, okay? This gentleman did quite well, right? He was placed onto some IV ABs. He was moved up to ICU for a short time and then moved down to the ward and was discharged a few days later. Still, he's had recurrent urinary tract infections. The blood in the colostomy bag had something to do with the way that it was attached. They knew about it before and they had a fix for it, and they fixed it while he was in hospital. So that's good as well. And what the paperwork kind of alluded to was that likely during the changes between the two, colostomy bag and indwelling catheter, there was probably not good hygiene being done. And that was probably one of the causes of his recurrent UTI, right? Was that there was poor hygiene done between those two processes.
That's what happens when you got 40 cats from your.
So yeah, that's a good point. Like the psychosocial kind of presentation of many of these patients. I mean, I don't know how I would be if I was a paraplegic living in Buell on a hospital bed in my own home, but I probably wouldn't be too concerned about my welfare.
Wouldn't want to wait on
You
that,
should see the house.
once I got my sepsis. You just prescribe me some more.
So this goes over to Stormy, okay? It's a nice segue into Stormy. For many of these cases, I think we need to have this thought in the back of our head, right? So we had our original patient in Kimberly in a very disheveled apartment on 300 Main, right? He was a recurrent patient. Our second patient ended up going via the route of hospice, right? She did not recover. She was in ICU for 3 or 4 days and they discharged her on hospice because she was on multiple vasopressors and they couldn't get her off of them. and they couldn't get her off of oxygen either. So they are gonna move her to hospice. This gentleman went home without much complication, like we talked about a few days later. But when you're looking at these patients socioeconomically and you go into their homes, have a thought to potentially think about Stormy and the KEMS team, okay? Because what we're trying to build as a healthcare system is just that, right? Somebody who can come into these places and help take care of these patients. So they don't get to where they're staying in our ICU for 3 or 4 days before they're discharged, or discharged to hospice in some cases. Obviously, the lady that got discharged to hospice was already in high care facility, but
Well, I'd say a facility.
well,
That's relative.
High care.
it was in a care facility.
Can we recall that she was found prone?
Yes, but they had seen her just hours before. They were taking care of her. So
They just started.
It just,
First day.
it just developed.
Not my patient.
Yeah, this was a very acute thing.
Well, that's interesting that you talk about, you know, the post-care as far as like chems and that kind of stuff, because when I was doing some research about sepsis and pulling some status from our patients, and I ran a report about a year ago that took our first set of vitals and it compared it to the Q-SOFA score. And then it identified what that risk was for them to actually have been diagnosed with sepsis. And it's about 90% accurate, just with our initial set of vitals. If they met Q-SOFA, that patient usually had that. And then I also was like, okay, so if they survived, to discharge, they survived sepsis. Well, no, surviving sepsis is actually considered surviving an entire year after they have been diagnosed with sepsis. And if they don't make it, they die within that year, it's considered part of their death, cause of death, sepsis. And so that's interesting that, if we see these patients that are homebound and we know that they're gonna go back home, it is pretty good idea to refer them to chems as well.
Yeah, so to touch on that a little bit, I mean, if you look at this guy, right, he's got a lot of comorbidities going on. Do we know how compliant he is with this medication? That's a huge one. Obviously, he's not a very clean person. We can help them find the resources to get rid of 37 of their cats.
Still gonna deal with him?
Yeah, we work with all of the home health. We work really closely. We actually are building like programs to help work with hospice. To identify patients earlier and get them on hospice earlier. So you guys would be seeing somebody that's maybe called multiple times and then be like, maybe they're a good hospice candidate kind of a thing. So these are all big things that we work on and try to keep people from going back into the hospital. So they get discharged a couple days later. He's gonna have a lot of issues for the rest of his life. Just we can educate and help with that. That's huge. So don't be afraid to send the message. We can't do anything. We can't do anything, right? We can lead a horse to water. We can't force them to drink. So I know.
Put their head in until they drink.
But most people also just don't understand. Like I had a lady who had diabetes for 20 years. When I asked her what diabetes meant to her, she said, I just can't have sugar. Like this lady is blind from this. She's got all these issues. She's gonna be on dialysis now. And that's all she understood about diabetes was that she just can't have sugar. So they need a lot of education.
Or QREs, or SAT chems holders.
Yeah.
I can't say that I've ever seen them feel.
I can't say that they have them still, but if they need some, it's my fault. No, I mean, it's not. I mean, it's a team effort.
The QRU has requested some chems information along with the red pouches. And so I just have never.
I think we're doing a little bit away with the red files. I don't think that those are gonna be in production anymore. But the red files are really nice, so. Yeah, we have, I mean, if you look at station
About 2 years, that's about per the course for the different things.
I think they have 1 million folders at station 1, so feel free to grab those for your use.
Thank you very much, Stormy. And like Stan mentioned, these patients are prime candidates to not do well long term. you know, if you want to, help your community, you know, it's really a positive thing to consider using all the resources that they have to. Okay. Which obviously, you know, we've got a great chems division here, so. Any other, crew insights? You guys did talk briefly about, you know, sometimes it takes a long time to get these patients out of their tight little, you know, apartments, their quarters that they're living in. You know, safety wise, did you guys identify any safety considerations for yourself, like masks or needs for, you know, gowns or anything like that? Cool.
Universal precaution.
Couple of little things though, but it's not in the protocol that we have to do a glucose, so that's one. Because I wouldn't have done a glucose on that patient. But just, you know, it's not in there. What it says, what it says is what it says if appropriate or something in there, I believe.
Okay, I think that's fine, but if we're altered mental status,
This one wasn't. No, so this one, yeah, they said it was mandatory. It's not, it doesn't say that. So we gotta make sure that's not a misconception, because I mean, if he's alert oriented, doesn't have any other history of anything, I'm not gonna poke his finger again. Sorry. I mean, if you make it mandatory, I'll do it, but I think it's not.
no, I don't think
Patient care.
I don't think
we
we
do it on
I
everybody.
agree, and that's what we did.
Yes.
But
But that's what I'm just saying. I mean, if we had our other catheters, it's no big deal, but what, you know, it's crazy that we.
In hindsight, his blood glucose was 88, so 88 is
Still normal, right?
exactly.
But I do
So-
think it's important to note though that elevated blood sugars over 200 with sepsis patients does increase the morality of the patient.
Sure it does. But I'm gonna treat this with fluid already, right?
Well, I know, but it's a good,
It's, I am not
it's
gonna
still a
do it. You're
good
not gonna
sign.
change my
Okay,
opinion.
I don't think we were trying to make that point. I think it's just something that came up on the other cases and probably carried over. I really don't care if they're not altered.
No, but I'm just saying, I don't wanna say that it's in our protocol
Yeah.
when it's not.
I don't think that's what we're trying to
That's
say.
the thing.
I understand how that came across, but that's not what it was intended.
Okay. And then secondly, entitled CO2 nasal cannulas, yes, they are expensive. Secondly, we had BLS providers putting them on patients that were coming in. That was a total waste of money.
Yeah.
So it needs to be appropriate. And then we actually had new providers that put them on because they want to see the waveform before they treated a patient. No.
That's true.
Okay, so that there's a bigger picture than it was the cost. There was a lot of stuff there, so I don't want to give that misconception. If it needs a patient, use it.
Indicated, absolutely.
But that's what they were doing. They're like, oh, well, I'm looking at the waveform, so I know, do I give them this or this, that? No, treat your patient, then get it going. So just so people know how that came about. It may not have been addressed appropriately at that time, but that's why. I mean, you got somebody that's truly BLS patient and they're putting this on, why you put that on? You're like, what's the reason for it? And that was why. So, what's that? They look cool.
They got that little orangey bit on.
So,
Yes, I mean, use good medical judgment, you know.
and that's what it is, and it is. So, but that
That
was
was the same with the sugar too, right?
Yeah, oh, no, that's what I'm saying. It's
So I mean,
definitely on the altered patient before, of course. Yeah, and it probably was done. I bet it was done by fire.
I bet it was.
And then, I don't know. Who's here? Yeah. I'll make two. So one of the things with the new on our blood sugars documentation on it is if we do it, make sure you do a timestamp under blood glucose. If somebody else does it, then document it and put it, you can put it in the vitals. I double checked. I was making sure what we were doing and that's what everybody, because right now it just says blood sugar. It doesn't show that we did it. It shows that it's on there. So, and that was one thing. It was brought up by a couple of reports and they said that they were told that we didn't have to do that. And so I didn't know until we found out.
And that's a very good point, because if you pull up just one of those charts real quick that you have there. Okay, when you look on the left column where it says cardiac med, hospital notified, those are things that are searchable, and those are things also that are included in the billing process. And when it comes to doing a lab, if a lab is just strictly a number in your vital line, like the glucose in your vitals documentation, that's not billable and that's not calculated, that's not searchable. It might be searchable, but it's not legitimate documentation for that. For it to be billable and be part of that calculation, and the majority of the searchable items fall into a category such as cardiac med, hospital notify, and lab. And that's why we have to document it using lab as when we collect the blood.
I just think it was a misconception because
probably
now
was.
glucose is on there. And then lastly, please enter their freaking medications.
Yeah, take that
I
extra.
don't know why almost everybody puts none on there.
Because it
In my
remembers
opinion,
it
it's
in the future.
laziness. Yeah, do I have to put in their own vitamin D? No. But it'd be nice to know what meds they're on. If you
Especially
document
like-
medications or you document all this history, but no meds, come on. We know that's not true.
Looking at me.
Yeah.
It's like when you're, I'm gonna go hide in the corner right now.
No.
Yeah.
It's just because you're that direction.
Yeah, good.
I'm just saying, it'd be
Look
nice.
over
I think
there.
it's laziness. I like to have it before and I look up patients on the way to a call. I'm like, have we been to this patient in Buell before? And you look it up like, oh, yes, we have.
If it's an address in Buell, yes, you've been there.
Exactly.
Yeah.
So thank you. Sorry, nothing else off my soapbox.
No, that's all great conversation and, documentation obviously is changing a little bit at the moment with things and how it's going. So, I tried to look for some cases, for this case review specifically that had a few documentations related things to discuss. And, we found a few. I didn't necessarily highlight the sickest of sick patients for this one because I wanted to have time to discuss a few of those small other issues like that. The blood sugar thing, like Stormy kind of mentioned it a little bit, but if you're thinking of it from a paramedic perspective, that's something that's going to potentially help guide your fluid administration for a query sepsis patient. If you have somebody with a high blood sugar, and I'm hoping Dr. Bruce will confirm this suspicion for me, at least this was my understanding of it. If you have somebody with a high blood sugar, that is a clear indicator that your patient is more hemodynamically shocked, right? Because they've lost more fluid. It's just like hypernatremia, right? You have high sodium concentrations in the blood. Obviously, we don't check electrolyte panels besides glucose, but any of these findings, high sodium, high sugar, going to push you down the route that the patient is severely dehydrated. Okay. And it's going to indicate to you that there's more of a need for volume resuscitation on these patients, right? And so, I mean, even though it says specifically in our protocol as indicated, I would hope that if you're querying any patient with sepsis, that you'll try to obtain a sugar, even if they're GCS 15, right? Even if they don't have a history of diabetes, because it's a really good tool we can use to help us look at how hydrated or how volume depleted your patient is. Okay. Right. Any other things anybody wants to discuss? Crew insight wise? Quality improvement there? How do you think Krista did on the job? Krista did well? Don't remember. Noah, anything from you?
I just got a set of vitals that called me and I was in Buell.
Yeah, cool.
No, I mean, yeah, it was, so the blood in the colostomy bag had nothing to do with sepsis.
No. No.
The only thing I might start to think about is if, I think I recall the patient was on antibiotics, so I'd probably want to check him for C. diff, because
They did, and he didn't
it
have
was
it.
right. But that's, if you were to look at this logical progression, that'd be something to think about, so.
GI bleed too in that situation.
Oh, yeah, sometimes if you're in shock, you can have information of the.
He was slightly low red blood cell wise, but they didn't think that it was necessary to transfuse enough red. So he was okay as far as I was concerned.
They have the
He-
side window.
That patient had a lactate of 4.6,
Okay.
2 hours into his care. So
So I guess a couple of points I just make about sepsis is, it really is just about recognition is the primary issue. And so I think, we can do fluids. Right now, we don't have antibiotics. I don't see the foreseeable future we we'll have antibiotics. However, there are places that have considered that. There's a whole other set of complications that comes with antibiotics in EMS, but I think that really streamlining the process. There's going to be some elements that we're not going to get that initial hypotension, the initial kind of appearance of the patient always comes up for me. Like when I'm calling it in to admit the patient, realizing like that initial hypotensive episode they had, the early resuscitation, but then just the summary. I think this patient is septic when you give a report. I can latch onto that really quickly and I'm with you. You know, you just give me the points as to why you think that. And boom, that's kind of it. So we can work on that process within ourselves, early recognition, initiating treatment, but then, you know, just the communication aspect of this is what I saw, this is why I think this is going on. That really moves the patient along. So if you can convince us like, hey, this is what's going on, you know, we could jump on board quickly, get the antibiotics ordered, get the cultures and all that stuff we need to do. So I think that's important. And then with the sugar stuff, you know, use your judgment. You know, it's just one of those things that it's information. If you can start a line and get it easy, great. If it's not absolutely mission critical, I don't want that. I don't want to mandate that. We just have too many mandates right now. You know, let's just focus on taking care of the patient. But if there's, you know, later you're like, hey, could that have been helpful? Maybe you should kind of recalibrate a little bit to be a little more inclusive on when to check it. But anyway, yeah, so those are kind of the summary points that I would make.
Just to kind of piggyback on your sepsis, I think at sepsis, I'm telling you, I think at sepsis, it's really the same thing that we're doing when we do a cardiac STEMI alert. STEMI alert, we actually have a 12-8 to back us up. But when we're doing a stroke alert, when we're doing trauma alerts, we're just heightening the fact that we found these findings and we're bringing this to your attention a little bit quicker.
I think it's actually received quite well, because when you, 99, basically all of you guys, if we're telling you these things, you guys are sitting there putting in the orders for, well, we want blood cultures, orders in, we want a full panel. You guys are doing all those things already while we're talking to you. So I think it's received really well when we bring that stuff up.
Yeah. It comes across as unambiguous, like these are the points, you know, and so that gives me a great starting point. So among the flood of other people trying to take my attention at the time or whatever other patient they're trying to drop off or ask me about, if you can give me those finer points of these are the alerts and these are the reasons, like I'm going to lock right into that and it'll be fine. So, I mean, I think that's the biggest point. It's just that recognition aspect and communicating it.
Nice. Thank you very much. Happy Turkey Day, everybody. Enjoy your Thanksgiving. Thanks online for those who dialed in. I'll be putting this recording onto EMS One Academy and sending an email out to everybody. So if somebody asks you about today and when, oh, why did Eric do a page review the day before Thanksgiving, blah, 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 you can just remind them to check their email.
And by the way, there will be a lot of old grannies with sepsis tomorrow because they're gonna see grandma. They haven't seen her for 8 years and she's acting confused. So we're gonna see a flood of that. So just be on standby. Be ready for sepsis. We'll probably treat her for a UTI with no shields. Oh, yeah.
MIs and UTIs. Everything with eyes at the end.
One cardiac staff every year.
Grandkids can be like, you know, she's been dementia for 8 years.
It works.
Okay, so yeah, it's complex.
The reason why I have like an issue with that is because depending on the progression and how compensated they are, that can either be high or they can be low. If they're early on and compensated, they'll see how high. If they're like later, so it's very compensated, then it's obviously it's gonna be low. And I think our single goal is, if, you know, with the variability in access, it's hard to kind of go off.
Yeah, there's a nice gems article on it, but it hasn't been recorded yet. But basically, like, think of it as like, it's really, you have to track the respiratory patients out of that, right?
Oh, yeah.
You're a COPD patient, you're like really retaining CO2. They're not gonna be chronic, it's not gonna be active, also, but you know, that's
Yeah.
two competing issues. Let's just say all things being equal, let's just say it's like urosepsis or abdominal sepsis. not getting good perfusion to the tissues, that you're not exchanging that CO2 to come in. Now, there is a tachypnea aspect too, but that was the biggest correlate. Now,
So the hypo.
but it's not 100% like correlation. It's not always 100% accurate, right? And so it can be useful if you're already thinking sepsis. And this person is, showing signs of shock, meaning that was, you can assume recently that.
Yeah, I don't think.
I think I would find words to use some things. I don't think that's. It's not gonna be. I didn't
Evo's only, and there's other competing variables, you know, the respiratory issues, you have the same need of observation on top of that.
Yep.